Hi, my name is Stefan Kovach, Clinical Educator Emeritus here at Healthmark Industry, and I want to welcome you to our 7 days of continuing education video series celebrating you, the medical device reprocessing professional, and all the hard work you do every day. You can work in a CPD, SPD, MD, RD, CSSD, and endo, a small clinic, ambulatory care, anywhere where you're reprocessing medical devices. This information is for you. Some say knowledge is power. We believe the real power is when we are all sharing our knowledge with others. That's what we're going to do over these next 7 days is share our knowledge with you because you truly are the heartbeat of the hospital, reprocessing those medical devices every day, whether they're scopes or instruments or trays or cut down trays, it doesn't matter. You're doing a great job every day. So each day of CS Week 2023, Healthmark will release new educational videos worth 1 CEU. Yep, that's right. 7 CEUs in 7 days, just as a thank you from all of us at Healthmark. Everybody at Healthmark wants to say thank you for doing a great job every day. We want you to keep this in your thoughts as you watch these videos. Remember that you are doing amazing things right now. Build on those successes to make change where change needs to be made. So, how do you get that certificate? It's easy as 1, 2, 3. 1, watch the video. 2, click on the video link description. 3, take the quiz and pass it. It's that simple. But we need you to do one more thing. Please fill out the feedback form so we can continue to improve. Tell us what you want to know, and we will work on providing that information. So now, relax, sit back, and enjoy as we share our experience and knowledge with you. And again, we thank you for taking time out of your day to view the programs we have put together. Have a great CS Week 2023, and remember to always keep it clean. Take care. Bye now.
Hi, this is John Whelan. I'm one of the clinical education specialists for Healthmark, and this is a program on endoscope processing standards updates. The 3 main objectives here are to identify the predominant organizations that provide the standards and guidelines, to highlight key provisions for training and competency recommendations, and to review key practice recommendations from these organizations. What are expected cleaning and disinfection and sterilization practices based on? Well, they're based on manufacturer's instructions for use, or IFUs, standards and guidelines, and your own written policies. Written institutional policies should reference national guidelines and standards and should always reference following manufacturer's IFUs. If you buy a new smartphone or a toaster and you never open the instructions, that's up to you. You're free to do whatever you want. In a healthcare setting, there exists the distinct obligation to not only have and keep IFUs, but to know the content and to follow the prescribed IFU steps in actual practice. This is where a lot of problems arise, as well as citations on external accreditation surveys, not knowing or following the IFU. And remember too, this is not just the device IFU, for example, the probe or the scope being processed, but also the IFUs for any processes. That would include brushes, automated equipment, chemistries like detergents, high-level disinfectants, and sterilants. Let's start with where practice guidance comes from. Where do the standards and guidelines come from? Well, there are mandatory regulations as well as voluntary standards and guidelines. Here are examples of common reference organizations. In the US, we're legally obligated to follow OSHA and EPA. It's regulatory, it's the law, you need to follow it. When it comes to the FDA and the CDC, you'd really be hard-pressed to justify not following guidance from them. Then we get into standards and guidelines from professional societies and standards organizations, like you see on the right side of the screen in the middle. ASGE, SGNA, AMI, and AORN. Accreditation and surveying agencies like Joint Commission and AAAHC, just to name a couple, use all the above as reference points, the regulatory as well as the professional societies and standards organizations. Again, this is not an exhaustive list. Depending on your services, you may have oversight from other accreditation agencies. Within the last 3 years, each of the 4 major organizations that direct processing of flexible endoscopes have published new guidelines. This includes, in order of publication, so reading from right to left, the American Society for Gastrointestinal Endoscopy, or ASGE, the Association for the Advancement of Medical Instrumentation, or AMI, the Association of Perioperative Registered Nurses, AORN, and most recently, the Society of Gastroenterology Nurses and Associates, SGNA. Key here is realizing that each of these replace existing publications. They are not simply updates or addendums. Remember, this presentation is not meant as a replacement for individually reviewing the documents in full. Historically in the US, SGNA has been the predominant driver for reprocessing guidelines in the GI endoscopy realm. Many GI endoscopy centers will focus primarily, if not all, on SGNA guidance. Shown here is their standard related to processing of GI endoscopes. Just within the past few months, SGNA updated their endoscope processing standard. Especially for those of you who work in conjunction with ORs and surgery centers, you'll realize that OR nursing staff tend to follow AORN guidelines. They have their own documents and guidelines related to flexible endoscope reprocessing. Their most recent guideline was published last September. ANSI is the American National Standards Institute. AMI is the Association for the Advancement of Medical Instrumentation. The 2015 document was replaced by a 2021 version that was published March of last year. It's titled Flexible and Semi-Rigid Endoscope Processing in Healthcare Facilities. It's worth noting that all the other organizations, governmental as well as professional societies, had representation and input for ST91. So that included the GI Physician Societies, SGNA, APIC, AORN, CDC, FDA, and TJC. ASGE is the American Society for Gastrointestinal Endoscopy. Since 2003, they've been the principal organization behind the multi-society guideline that represents multiple professional organizations, predominantly including GI physicians and nurses, as well as infection prevention. You'll note, as you see on the emblems here from their cover page, that AORN, APIC, and SGNA were supporting member organizations for the latest document. The latest version of this guideline was published January of 2021. It is then necessary that healthcare organizations and frontline staff have access to the most current version of these references, and that institutional policies and practices reflect up-to-date recommendations. Accreditation and surveying agencies routinely ask which organizations are referenced, and then they survey to those as well as your own policy. Useful then is to know within your organization which standards, guidelines are the reference points, and then what the associated standard or guideline recommends as expected practices. Whether one or several organizations are referenced in endoscope processing policies differs from one healthcare organization to the next. It's not required that only one organization is referenced. Each of the organizations reinforce the need for ongoing focused training and competencies for any and all staff performing endoscope processing. Let's take a look at related recommendations. When it comes to endoscope processing specific certification, again, that's endoscope processing specific certification, AMI ST91 is the most prescriptive in stating that processing staff should be certified within 2 years of employment and should maintain that certification throughout their employment. Examples of existing endoscope processing certifications are offered. Certification by itself does not replace the need for ongoing training and competency assessments. Formal training and competency assessment occurs before independent practice and reoccurs minimally on an annual basis. Training and competency occurs also when new endoscopes or processes are introduced. For endoscope processing specific certification, the SG&A reference is to consider certification. When it comes to education, training, and competency, SG&A reinforces to strengthen training and education for processing staff, undergo more frequent validation of competency for specialty endoscopes that are used infrequently, that temporary personnel should not be processing reusable devices until competency has been established, just like regular staff. And processing staff are trained and demonstrate initial and continued competency. Related to education, training, and competencies, the Multi-Society Guideline speaks to including standard infection prevention and control content, endoscope model-specific reprocessing instructions and training, that training and competency occurs and is documented before being assigned to perform high-level disinfection or sterilization of those devices, that competency evaluations recur on an established schedule, and again, that temporary personnel require the same level of training and competency as regular staff. When it comes to education, training, and competencies, the most current AORN guideline reinforces training and competencies for staff, as the other guidelines do, but also speaks to the responsibility and competency for those that manage staff who process, as well as those that provide training and education. So it's not just the frontline staff that need to have training and show competency. Noted is reference to competency verification for each model of scope process, and to consider increased frequency of training and competencies for models that are used infrequently. Let's now look at key practice recommendations from these organizations. For the organizations and documents at direct processing, these are the common foundational reference points. And remember that standards and guidelines evolve over time, and this continues to be a work in progress. Note that besides AAMI, AORN, SG&A, and ASGE, direction also comes from FDA, CDC, and accreditation agencies. Little by little, these organizations are coming together on key content, especially related to quality control and evidence-based practice recommendations. The real benefit then to the frontline user is that the various guidelines are more complementary than they've been in the past. That's not to say that different interpretations and recommendations don't still exist. This then helps provide a foundation to guide policies, as well as all members of the team, processing professionals, clinicians, infection prevention, and others, to establish expectations, continuously monitor quality, and as needed, report any practice breaches. Some of these common key quality recommendations include direction given related to training and certification for staff, as we just covered. Process monitoring receives critical emphasis. Traceability of reusable devices and their processing back to patients. The ongoing need to perform institutional risk assessments. An emphasis on documentation and quality assurance. To further help address the objective, let's reference the steps of processing. What you see here is very much an oversimplified list to represent the basic steps common to both HLD and sterilization, from clinical use through processing to storage. What's done at the bedside was historically called pre-cleaning, It's now referenced as point of use treatment. Important points at this stage. This is the initial removal of organic material, and it's critical to decrease the bioburden load for any subsequent steps, be it high-level disinfection or sterilization. Pre-cleaning point of use treatment always occurs right after the procedure in the procedure room at the bedside. It includes actual pre-cleaning, but it also includes removal of accessories, preparation for transport, and communication to processing personnel. All organizations reinforce the need to follow the IFUs for point of use treatment. AAMI and AORN call for keeping scopes moist for transport to keep bioburden from drying. This isn't a new concept related to surgical instruments, but it is a new mentality and expectation related to flexible endoscopes. AAMI and AORN also identify the need for handoff communication to identify the time that point of use treatment pre-cleaning was performed. And that's because time is critical. We need to limit bioburden before it has a chance to dry. Follow the endoscope manufacturer's IFU related to delayed processing protocols. For the step of leak testing, once again, following IFUs is reinforced. And here it is both the endoscope manufacturer's IFU as well as the leak tester manufacturer's IFU. AORN and AAMI highlight the need to perform and document pressure outputs from leak testers to help ensure any and all leaks are identified. The rationale here is that if a leak tester is not delivering correct pressure outputs, leaks can be missed, and any leak matters, however small or large. This pressure output quality control testing would occur whether it be an automated or manual leak tester. For AAMI, this would be done each day that endoscopes are used. Any scope failing leak testing or discovered to be damaged should be individually labeled or tagged and managed per facility repair policies. All organizations continue to emphasize manual cleaning as critical to success for processing. SG&A refers to it, for example, as the most critical step in removing bioburden. All organizations stress the need to have brushes that are compatible for the lumen size. SG&A, AAMI, and AORN state that single-use brushes are preferred. Increasingly, we have the existence of automated endoscope processors, or AERs, with automated cleaning claims. SG&A strongly encourages maintaining manual cleaning and channel brushing, even prior to AERs with cleaning claims. They emphasize that such redundancy provides an extra level of safety. AAMI and AORN recommend performing a risk assessment if considering foregoing some or all of manual cleaning. And remember, for duodenoscopes, full manual cleaning is still required for the IFUs as well as FDA direction. All organizations promote the use of light and magnification as part of focused inspection following manual cleaning. Lighted magnification is what we mean when we call out the need for enhanced visual inspection. We're purposely enhancing what we can see with the naked eye. SG&A highlights inspection as a unique step that serves as a safety stop or a timeout. And they note that it's the minimum standard for cleaning assessment. AORN directly promotes the use of borescopes for accessible channels. Any soil and or biofilm that remains after cleaning can interfere with the disinfection or sterilization process. So cleaning verification is part of focused inspection. It is AAMI, AORN, and SG&A that speak to the need for cleaning verification testing as part of inspection after manual cleaning. AAMI and AORN declare the need for every cycle cleaning verification testing for high-risk endoscopes. The definition for high-risk endoscopes includes those associated with infectious outbreaks, those that are difficult to process. So it would include elevator channel endoscopes, so duodenoscopes and linear EUS scopes, as well as bronchoscopes, cystoscopes, ureteroscopes, and endobronchial ultrasound, or EBUS scopes. It can also include those as determined by facility, so a facility can choose to add to the definition of what they want to consider high-risk endoscopes. For non-high-risk endoscopes, for example, colonoscopes, gastroscopes, cleaning verification tests should be performed when new scopes are purchased and at established intervals, and this should be based on a multidisciplinary risk assessment. All organizations speak to the preference for and value of automated processing, especially to allow standardization and limit the human error element. When it comes to high-level disinfection, AAMI has focused statements against manual disinfection. Manual guidance is given, but automated processing is promoted. They promote that manual guidance should be reserved as a backup option only for when automated processes fail. AORN, AAMI, and SG&A direct that scopes should not be left in AERs for extended periods, with AORN and AAMI pointedly stating more than 1 hour would require a repeat HLD cycle. AER basins are wet environments, and the intent here is to limit the chance of waterborne contamination. One of the more noticeable changes to all 4 standards and guidelines is the emphasis on active channel drying post-AER. In unison, all organizations call for a minimum of 10 minutes with automated filtered air. This needs to occur after the AER. The AER cycle is a purge only, not a validated drying cycle. Active drying is required whether the scope is headed right to another procedure or to storage. Related to alcohol flushes, SG&A promotes using alcohol flushes. ASGE states to follow endoscope manufacturers' IFUs. AAMI and AORN recommend to follow IFUs, but consider a multidisciplinary risk assessment to determine and decide whether to use alcohol flushes in practice. An endoscope post high-level disinfection looks similar to an endoscope right after bedside cleaning. So to have visible process indicators and prevent misses and near misses, it's important to ensure that a system exists for identifying patient-ready scopes. SG&A and ASGE reference tagging as one possible system, while AAMI and AORN call for a distinct visual cue that a label or tag should be attached to the process endoscope. And this is regardless of what type of storage cabinet exists. When it comes to storage for flexible endoscopes, the important preface from everyone is that scopes need to be dry first. Moving forward, endoscope storage cabinets with only passive airflow should not be used. AORN and AAMI state that drying cabinets are preferred, but if not available, then cabinets with active ventilation are required. To handle an endoscope post-processing to or from the storage cabinet, hand hygiene, clean hands, and clean gloves are required. The only organization still referencing a distinct number of days for endoscope storage expiration or hang time is SG&A, citing a research study from 2015. The other 3 organizations recommend basing hang time on a multidisciplinary discussion and review of available clinical investigations and research. None of the organizations require routine post-processing surveillance, but reinforce if and when it is done to follow the established FDA, CDC, ASM culturing protocol. Options for surveillance testing include traditional culturing and gram-negative testing. This is not cleaning verification, nor is it ATP testing at this point. Surveillance testing looks for evidence of microbial contamination. This slide shows current guideline reference to microbial surveillance. Significant to note is that FDA-mandated surveillance testing showed that 5.4% of cultured scopes were positive for organisms of concern. Related to the Spalding classification system for semi-critical reusable devices, it wasn't intended that HLD was the one and only option, but rather if sterilization was not possible, then high-level disinfection. Where we landed over the years is having a predominance of flexible endoscopes undergoing high-level disinfection. As we know, flexible endoscopes are heat sensitive, so they're not compatible with steam or other sterilization modalities. ETO sterilization, while compatible with many scopes, is not available to many facilities. Both AORN and AMI promote the routine use of existing sterilization modalities for any scopes that are manufacturer validated for sterilization when possible. Meaning, if you have the means to sterilize and it's validated in the IFU, we should be moving in the direction of sterilizing those scopes. Remember that this crosswalk serves only as a very brief overview for some of the key points in the latest guidelines for endoscope processing. It's prudent to individually review the documents in full. We always emphasize the need to seek proven information for best practice from standards and guidelines organizations, professional societies, and peer-reviewed literature and research. I appreciate the opportunity to share with you today and your commitment to quality and advocacy for patients. Please reach out for any questions or if we can offer anything additional.
Hi, I'm Marianne Drosnock, Director of Clinical Affairs here at Healthmark Industries. I'd like to thank you for watching today's CE program. If you got something out of today's video, please hit the like button and then be sure to subscribe to the Healthmark Education channel so you can know as soon as we post more educational content. By liking and sharing our videos and by subscribing to our channel, you are helping us grow. That way we can share the message of patient safety to more sterile processing and endoscopy processing communities, as well as our OR and IP partners. To get your 1 CE certificate for viewing today's video, there is a link in the video description that will take you to the quiz. Just complete the quiz with a 70% or better, enter your name and email, and you will be issued a 1 CE certificate immediately. You can download that certificate right to your device, or it will be emailed to the address that you provided. Thank you again for watching, and we hope you had a great CS Week 2023. Bye.